Greetings, aspiring orthopedic clinical specialists. We are going to review our lumbar spine case today. So what we're going to do is we are going to go over the case, and I'm going to tell you some of the important information that as I read this case, things that I'm going to pay specific attention to, because they will probably help me put the case together and answer some questions. So as I'm reading these scenarios, I'm thinking about what condition is most likely present, what interventions are most appropriate for those conditions, and that's the information I'm trying to pull out of the case. So we'll go through that. We'll go through the questions. We'll talk about why the key is correct, or why the correct answer is correct, and why the distractors are plausible but yet not the best answer. And that's one thing we want to think about when we read these and look at these questions. It's not always about what choice is 100% incorrect, but what choice is the best choice. Because when these questions are written, we'd like all the options to be plausible. So you have to understand why the best answer is the best and the other answers are not the best. So we look at this case with our patient with lumbar spine pain or low back pain, 42 years old. Anytime you're given an age, I want to pay attention to that, because as we know, there are certain conditions that are more prevalent in certain age groups. There's certain conditions that we're going to see only in certain age groups. So I want to know that this person's 42 years old. We're told that they're a female physical therapist. So the fact that they're female may or may not come into play, but it's not something I want to ignore. And the fact that they're a PT probably means that they have a physical job and they're moving around, as we all know. So those things mean something to me. We have a 2-week history of severe low back pain. So it's 2 weeks, so I'm thinking acute, but it's severe low back pain. And we have right leg pain. And this was sustained after a lifting injury while transferring a patient at work. So we know that this was something fairly physical. It's not insidious. We know that we have a specific mechanism of injury here. And then we're given information about her presentation, that this pain is sharp and shooting. So that should mean something to us. We should be thinking about potential neuro involvement or nerve irritation if we're talking about sharp shooting pain. Originates in that low back, travels down that right leg into the calf and the foot. So we know where we have pain. That should potentially help us think about maybe some lumbar levels that we would be thinking about if that's where the pain is traveling to. And then we're also told that we have intermittent tingling and numbness in the right calf and the foot. So again, tingling, numbness, we think of neuro involvement. Peripheral nerve, maybe it's a disc pushing on a nerve root. We start thinking about that. Symptoms are exacerbated by sitting and standing for extended periods of time, coughing and sneezing. So those should mean something to us as well. We love to know what makes the condition better, what makes it worse, helps us figure out that differential diagnosis piece. So when I see those things, I start thinking, could this be a disc, especially with the coughing and the sneezing piece? Symptoms are minimally relieved by over-the-counter medication. So we're not told that any type of movement or position limits our symptoms. It's over-the-counter medications that minimally relieves our symptoms. So again, pretty severe case. We have difficulty walking on the toes and weakness in that right foot. So now I'm definitely thinking about some kind of nerve root involvement or pressure on a nerve root. And we deny any changes in bowel or bladder habits. So those are giving us our red flag information. So I'm thinking, this is not someone I have to think about referring out. This is someone that I should be thinking about treating, and I should be able to treat them fairly effectively as a PT. And we're given our Oswestry score. So a point about this, make sure we know our outcome measures. We want to know what outcome measures are appropriate for certain conditions or certain areas of the body. And then we want to know those scores, because here we're just told we have an 80 on the Oswestry. For some outcome measures, a high score means that the person is functioning really, really well and has limited disability or limited impairment. On other outcome measures, a low score means that the person is functioning really, really well and has limited impairment. So on the Oswestry, as hopefully we know, a high score is worse. If they score higher, they're not doing as well. They have more impairments. So an 80 means that they're really, really limited. They have a lot of impairments. And then we're given information about our clinical examination here. Decreased lumbar lordosis, antalgic gait, things that probably make sense with our presentation here. We're given our neurological exam. So we have decreased sensation on the right peroneals, which we would call fibular muscles now, and lateral dorsum of the foot. So again, we start thinking about what nerve root, what lumbar region is going to produce symptoms in those areas. We have decreased strength of dorsiflexion and a reduced Achilles tendon reflex. And she cannot perform a single heel raise on the right. So again, I'm thinking of nerve root involvement when I start putting that information together. And then the last piece we're given here is special test information. That positive straight leg raise at 30 degrees. So again, we want to know our special tests. We want to know what tests are appropriate for which condition or diagnosis and what a positive test is. For some special tests, as hopefully we all know, pain makes it a positive test. For other special tests, pain doesn't necessarily make it positive, but it's more of an instability finding. So we want to know our special tests and what's going to make them positive or negative. So here, positive straight leg raise at 30, it's pretty severe. And then we have a positive well leg raise test as well. So we raise the left leg, the leg that she's not having symptoms in, and we get that low back pain and pain down that right leg. So this just all puts us to thinking about that we have probably some kind of nerve root issue, nerve root compression, probably maybe a disc, and it's fairly severe at this point. And then the last piece that we're given, she's motivated to return to work. So that is very good because that gives us some psychological insight, and maybe that's a question coming up later. So that's our case, and that's how I proceed through it, and that's the pieces of information that I pull out and that I start to try and interpret. Our first question is, which of the following diagnoses is most likely? So all of them start with acute low back pain. It's 2 weeks, so we know that. Our best choice here is B, acute low back pain with radiating pain. With radiating pain, because we have radiating pain coming down that right leg. So that's definitely checks off those boxes. And this information, again, is coming from our clinical practice guideline, the 2021 revision, in terms of the classification piece here. So when we look at our other options, A, acute low back pain with mobility impairment. Yes, we have acute low back pain, but we weren't given any information about hypomobility either being reported or found during the exam. So that one is not the best choice. Maybe it's not 100% wrong, but acute low back pain with radiating pain is a much better option. C, acute low back pain with movement coordination impairments. We're not given any information about aberrant movement, about hitching or juddering when she moves, so that would not be the best choice. And then acute low back pain with related cognitive or affective tendencies. We're motivated to return to work, and we don't have any other information about her lack of cognition or anything like that, so that is not the best choice. So our best choice for diagnosis that is most likely is acute low back pain with radiating pain. Our next choice, or our next question, given the presentation, what is the most likely dominant pain mechanism involved in their presentation? So why are we having pain? And we look at our choices and we have types of pain. Our best answer here is neuropathic pain. So B, neuropathic pain, because we have our neurogenic symptoms. We have our decreased reflexes. We have decreased strength in a myotome. We have radiation of pain. It all fits into that neuropathic pain presentation. Nociceptive pain would be a specific tissue being irritated and giving us pain. And that's typically pain without radiation, and it's pain at a specific site or in a more specific area. So the fact that we have radiating pain down the lower extremity gets us away from the nociceptive piece. And our nociplastic pain is incorrect because we don't have altered nociception here. The patient is interpreting pain or perceiving pain correctly. We don't have altered nociception where we're talking about itching or anything like that, and any strange kind of symptom. And then central sensitization is not our best choice either. Patient is motivated to get back to work, and we don't have any type of hypersensitivity reported here. We don't have any information about that. So when we look at the reason why this patient is having pain or the type of pain this patient is having, our best choice is neuropathic pain because it checks off all those boxes. And then our last question, we're asked about intervention. Given that presentation and the suspected diagnosis, what would be the most relevant intervention for today? So right here, while this patient is sitting in front of us, that's also really important to pay attention to. It's not asking about prognosis or future treatments. It's asking about what you're doing today based on just the information you have. So there's a big difference about interpreting information and assuming information or assuming facts not in evidence. So our best answer here is going to be neural tissue mobilization. We think we have nerve root involvement here. We have radiating symptoms and we have numbness and tingling, and we have those findings. So we would want to get that neural tissue to move a little better. So neural tissue mobilization is going to be our best choice here. Flexion-based exercises would be incorrect. We weren't given any information about a directional preference. We had issues when we sat or stood too long. So it wasn't like one position was much better than another position. So flexion-based exercises, there's not enough information for us to say, yes, definitely flexion-based exercises would be great. And if we look at B and C together, aerobic exercise and aquatic exercise, those are both going to be good for her. Get us moving and get us more mobile. But they're not specific to the presentation. So if we didn't have neural mobilization as a choice and we had something else, then aerobic or aquatic exercise might definitely be appropriate. But because we have neural tissue mobilization, that is a more specific choice to her specific presentation. So that is our best answer here. So again, B and C, aerobic and aquatic exercise, not necessarily wrong. They're plausible, but they're not the best answer given the information that we have based on the patient's presentation. So hopefully that gave you a little insight as to how we want to interpret the surveys and the scenarios, and how we want to put that information together and interpret it, and then how we go through that process of answering these questions. And in this case, we had a diagnosis question, so what condition is present, a couple of diagnosis questions, and then an intervention question. So when you read scenarios, it's always a good idea to think in that vein. What condition is most likely present? What interventions would be most appropriate? Because that's probably what you'll be asked.